Well, welcome everyone. Let's make a start. I'm Channa Hewamadduma, neurologist from Sheffield. So I'll be chairing this webinar today, and I'll be joined by two of our well-known myasthenia gravis colleagues, Dr. Pablo Garcia-Reitboeck and Ms. Jude Kings. And we're going to talk to you about today monitoring myasthenia gravis in clinic and choosing outcome measures and how are they relevant to our clinical practice. And I would like to thank our sponsor, Argonex, who has sponsored this symposium. And after these discussions, we have a sponsored webinar afterwards as well. So we'll be very grateful if you hang on. So for the first part, we will have Pablo and Jude talking to us. And then in the second part, we will have Pablo and Phil Ambrose, neurologist from Nottingham University Hospital, who will present to us some cases illustrating the use of novel therapies and outcome measures in patients. So the timeline of this webinar is from 6 to 6:45. We will have the Neurology Academy session, which is with Pablo, myself, and Jude, and then we'll have a 5-minute break. And after that, please join us for the Argonex Promotional Satellite Symposium with Pablo and Phil Ambrose. So the reason why we thought we'd select the topic of outcome measures is because we know the advent of new therapies, and a number of these therapies are now in pipeline for NICE and other regulatory bodies. And there is the need to classify and identify the severity of our patients, because there are criteria outlined who can and cannot have these therapies. And these severity scales are also the outcome measures used in the clinical trials. So there is the need to understand these outcome measures and to understand their limitations and how you interpret. And they also help us to understand whether our therapies are working for our patients. So let's take a deep dive into this. And I would like to welcome our first speaker, Pablo. He is a consultant neurologist from St. George's Hospital, and he's a senior lecturer at St. George's University London, and he trained in medicine in Vienna and Paris and earned his PhD in clinical neurosciences from Cambridge, and he's at St. George's Hospital, where he runs the motor neuron disease clinic and myasthenia gravis clinic, and he's a principal investigator in several research studies as well as the clinical lead, and he enjoys teaching. So over to you, Pablo.
Okay, thanks, Channa. Yeah, thanks everyone for joining us this evening. So I run the myasthenia gravis clinic at St. George's and have done so over the last 6 years. And this, in a way, outcome measures are also sort of a personal journey, which I've started to use these more and more in clinic. So measuring myasthenia gravis activity with outcome measures is has been done for many years in clinical trials. There's a number of scores, such as, and I will talk about these in more detail: quantitative myasthenia gravis score, MG composite score, MG ADL score, quality of life scores. They're used in a research setting traditionally, but have in recent years been increasingly used in clinical practice. And some of these lend themselves for remote monitoring as well. And we'll show some examples about this. So the MG ADL score, Activities of Daily Living score, has been around for about 25 years. It was initially reported by Dr. Barron's group. It's an 8-item patient-reported scale. So patient get a questionnaire they can fill in about myasthenia symptoms and their functional status. It's often used in myasthenia gravis trials, traditionally as a secondary endpoint, but more recently as a primary endpoint, and has been increasingly used in clinical practice because it's very convenient to use and for patients and clinicians. So these are sort of the scoring system. You can see it is divided into bulbar symptoms, respiratory symptoms, limb symptoms, and ocular symptoms, and patient will score themselves as a total score of 24. The higher the score, the worse of the disease activity. The quantitative myasthenia gravis score is a gold standard outcome score for myasthenia gravis trials. It is often used and traditionally as a primary outcome measure, but it requires a lot of time. So it's a mix, not just patient-reported symptoms, but also clinical examination in clinic. And it requires a dynamometer and a spirometer. And this is impractical in clinics because many places will not have a dynamometer. And if it takes 20 minutes to complete, the follow-up appointment is just not feasible. Colleagues in the US have also now almost 20 years ago devised this MG composite score, which is a score that is sort of a mixture between patient-reported symptoms and clinical examination, but it's much faster. It takes about 5 minutes. I use it in clinic all the time on a majority of patients. And this is sort of the scoring system. Again, you have ocular signs. You will look for fatigable ptosis, fatigable double vision. You have some patient-reported bulbar symptoms because they're not easily examinable. And there's sort of an overlap with MG-ADL questions. Your breathing is another symptom you don't measure, the breathing respiratory function. And then you look for neck flexion, weakness, neck extension, weakness, and limb weakness. But this is not fatigable weakness. This is you examine the patient without repetitive movements. Just to briefly mention the MG-QOL score, Jude is going to talk about this. But the reason this is another sort of patient-reported outcome score where patients score themselves. I mainly mention this because one question is what constitutes a clinically meaningful change, and maybe we can discuss this afterwards. And there have been some studies that try to address this. And you can see from this study here that tried to compare MG composite score, MG-ADL score, and was also a muscle sort of score that we don't use frequently, well, generally in clinic. And has looked at sensitivity and specificity when compared to the MG-QOL score and physician impression of improvement. And you can see that, for instance, for MG-ADL score, the higher the difference score change, it becomes more specific, but you also lose sensitivity. So, between 2 and 3 would constitute a meaningful change. But that's sort of for discussion. Different trials have used different cutoffs in terms of labeling MG responders. And the same is true for MG composite score, where a change of 3 seems to have sort of the best mix of sensitivity and specificity. This is just to show outcome scores in research settings. So this is from FKT trial, and you can see in red the placebo curve, and in blue the response curve, and you can see that these outcome measures correlate very well with each other. Okay, so now with that said, I've got some cases. So first case is a gentleman at 73 and has acetylcholine receptor positive myasthenia gravis now for a few years, mainly with bulbar symptoms. Had myasthenic crisis in 2020, treated with IVIG, and also relapse more recently in 2022. And in the last sort of years and months, we've weaned him off steroids and recently stopped his steroids. So this patient was in clinic about 2 weeks ago. And he filled in these questionnaires, and I examined him. So MG-ADL score, MG minimal symptom status is usually defined as 0 or 1. So he's clearly symptomatic from his myasthenia, and that sort of correlates with his MG composite score, where you can see that he's got mainly bulbar symptoms and ptosis. But we can again discuss how active his disease was. But to me, it led for me to reintroduce him on a small dose of steroids and consider steroid-sparing agent if we need to increase his steroids by a significant amount of time. So to relapsing myasthenia gravis, not of requiring admission to hospital, but definitely a treatment change. Case 2 is a young woman in her 30s who's had myasthenia gravis for many years. She's actually known to a different center initially, but because she lives close to our center, transferred her care over. She's on 4-weekly IVIG. She actually tried efgartigimod, had partial response, but not so significantly enough to continue. And she had the first time I met her was when she was admitted to intensive care in late 2023. And these are her scores. So initially, with her hospital admission, she had a very high MG composite score and high MG-ADL score, which then improved with IVIG and treatment. I also started her on steroids. And you can see that her MG-ADL score, so I asked her to send me MG-ADL scores every week by email. And we'll talk about ways to monitor remotely, but this is currently what we do at St. George's. So every week she would email me a score to either reassure me or for me to admit her for IVIG sooner. And you can see that it creeps up the MG-ADL score, then she gets IVIG, then it comes down again. But we're able sort of to keep the myasthenia at bay. And this is sort of, this is the case with IVIG or with plasma exchange, other drugs, that you try to find the, sort of individual treatment options for the patient. So you don't give it too frequently, wasting resources, but also for the patient, not good to come in very frequently. But you also don't want patients to relapse if the treatment interval is too long. Case 3 is a patient who's older, in his 70s. He's got comorbidities. He's got type 2 diabetes, asthma. He walks with a stick. He's got arthritis, and he's been treated for many years for acetylcholine receptor positive myasthenia gravis. Has tried a number of treatments. He was on plasma exchange, regular plasma exchange. And I switched him to efgartigimod. He reported improvement on efgartigimod, but his MG-ADL scores didn't seem to change. And it's sort of an interesting example because in the trials, the MG-ADL score improvement, you would expect to be at least 2 to classify someone as a responder. And in his questionnaire, there doesn't seem to be much change, maybe just 1 point. But when he comes to clinic and when I examine him, he's clearly no longer weak in his limbs. His MG composite score is much better. So that shows maybe the limitations of patient-reported outcome scores, that if there are comorbidities or if patients are a bit older and frailer, some symptoms that they describe might not be because of myasthenia. One thing that we're trying to move to is remote myasthenia monitoring, and Jude will talk about her experience. So what we want is for patients to be able to tell us how the myasthenia gravis is in a sort of easy way. And there's a system we're trying to use where the patient has an app and can fill in their questionnaires on an app. We have a portal where we can monitor patients. These are made up names. These are not real patients. We don't use the system at present. And you can see you will have a dashboard where patients are flagged if their myasthenia gravis gets worse. And that sort of enables you to keep track of patients, especially brittle patients, because many patients will be well controlled, and it's okay to see them every few months or less. But there are some patients who are very brittle, and you need to keep a close eye on them. And that's maybe one way to do it. And again, we can discuss about remote monitoring and sort of whether this saves time or increases workload for clinicians and healthcare professionals. But what is useful is longitudinal monitoring, so you can see the trend rather than having to put this into a spreadsheet yourself every time. And for the patients, they can learn about the myasthenia gravis as well, using the app. And it's not just about the symptoms, but they can also put in their medication. And so I think that's the way forward, not just for myasthenia, but for many, I think for healthcare in general. Okay, and that's for me.
Well, thank you very much, Pablo. That's really insightful. And can you to the attendees, would you mind please forward any of your questions using the Q&A function at the bottom of your screen, and we'll be able to pick it up, and let's make it very interactive and learn from each other's experience. So before Jude comes in, and whilst the others are thinking about questions, may I ask a couple of questions, Pablo? Could you tell us how you select the outcome measures? Do you do the MG ADL and composite myasthenia gravis on all of the patients?
Yeah, I would do MG-ADL on everyone who comes to clinic. They will get the questionnaire ideally when they sit in in the waiting room, and then bring it in. And so the patients who are brittle, either they are on regular IVIG or have had recent crisis, I will ask our coordinator to email them the questionnaire, and then the patients email them back, which is a significant bureaucratic effort, and also for the patients not easy to fill in. And that's why I'm a bit jealous about Jude's system, and hope we can introduce this very soon as well. But in terms of choosing the outcome measures, so the quantitative myasthenia gravis score was never a question. I wasn't able to do this in a sort of 20-minute follow-up appointment if we're meant to, go through the symptoms, the medications, discuss changes. But so the MG composite score is really very quick. It's very fast to do, so MG-ADL and MG composite score for me has proved very valuable. Now, during this webinar, I'm reading more about MG-QOL score. I wonder whether I should introduce that as well, and wonder whether other centers do this regularly. There's also questions: how many questionnaires does a patient want to fill in? So that's another question. But yeah, MG-ADL I find extremely useful. MG composite score, just to have sort of that sort of confirmation in clinic by examining the patient as well.
And you're right. I think to do the composite score, it doesn't take very much, because part of the history and some of the confirmatory examination that you normally would do with an MG myasthenia patient will automatically fill that up. Now, you mentioned, Pablo, that there are patients with, like one of the last cases, where they had comorbidities, that they might have COPD or asthma, or they might have hip replacement, therefore their walking is difficult and standing up is difficult. So when you score your MG-ADL with that patient, would you ask the patient to think as if they don't have COPD, or do you score it along with the comorbidity?
Yeah, I mean, that's a good question. I haven't sort of tried to coach the patient to sort of imagine, dissect which symptoms are for myasthenia and which aren't. I think one question that's very difficult is sort of respiratory symptoms, and sort of the breathing scoring, because if you have any lung disease, you will always score this. If you're out of shape, you will have exertional shortness of breath. So, it says myasthenia related, but that's sometimes a bit difficult to dissect. So that's difficult, and maybe that's of measuring vital capacity in clinic comes into play.
Oh, thank you. And there are a couple of questions come up on the Q&A. Dr. Ahmed asks a question about MG-ADL and myasthenia gravis composite scores. A decrease of how many points would indicate a significant improvement of the patient? So, in other words, what are the clinically meaningful differences in the two scales?
So, I mean, that's a good question. That's just something that's I think up for debate. I mean, the slide I showed before, where they see they looked at sensitivity and specificity of MG composite score, MG-ADL score. Obviously, the higher the difference in score, the more significant or specific it is. But maybe that you lose sensitivity. So, in these studies, they thought, MG-ADL score of about 2, and if you hear about FKT modulator in their trial, they used a cutoff of 2 for to classify some of the MG responders, and no other studies have used 3. Channa, I'm sure you've got your own view of what constitutes a meaningful change. It also depends on the outcome score. But sometimes there will be dramatic changes. We have someone admitted with myasthenic crisis, but not known first, unknown myasthenic crisis, and once you give patients IVIG, that some of them and patients will usually respond very significantly from and have their myasthenia MG-ADL or MG composite scores or less. So but yeah, so if there's sort of minimal change, it's a bit difficult, and I think that you probably have not just rely on scores but also on clinical clinical assessment. And some patients have a functional neurological disorder as well, and that becomes much more difficult.
Yeah, in other words, you need to have a good understanding of your patient over a period of time, and in order to get an interpretation of the scales. But in clinical trials, they use 2 or more point improvement or deterioration as a minimum difference that is required to coin that someone is deteriorating or getting better from MG-ADL point of view, and 3 points, as you said, for the composite myasthenia gravis score. A question probably, Jude, you might be able to answer, or maybe you can elaborate it in your discussion, is how can you enroll patients into an app? Okay. Are you going to talk about it?
I'm going to talk about it in a little bit if you want me to. Yeah, and it's taken a few years. It's taken 4 years since we've got it up to encourage people to use the app, but yeah, it's definitely made my life and the 2 consultants I work with, it's made our life easier from a point of being able to monitor. And I'll show you sort of, it's similar to the one that Pablo's looking at, where it shows on a graph timeline. You can really easily see, so it's trying to engage everybody, and we recognize that not everybody has the either technical skill or the want to do it. You might find it's the patients who are have active disease who will be more likely to be using the app as opposed to patients who they're back in remission, they're fine, thank you very much, they don't need to do it. So it needs a lot of encouragement and reminders sometimes to get them to do it.
Thank you, Jude. I'm sure you'll elaborate a little bit more in your presentation. That's a great answer. And there's one last question about do any of the outcome measures use FEV1 or forced expiratory volume?
I think only the QMG score measures spirometry. So the MG composite score will score symptoms, which as we said, can be difficult if patients have comorbidities.
Yeah, I think you're right. That if these scales don't capture all the symptoms, for example, MG-ADL doesn't capture patients with who have significant neck weakness or head drop, and then some patients have distal weakness, the hand weakness or the foot weakness. I have a patient who develops bilateral foot drop, and we excluded all other neuropathic causes, and reptostim was completely abnormal in the tibialis anterior, and this patient, that MG-ADL doesn't really pick up on the distal weakness. So you might want to use a scale that you're familiar with, which might help you, for example, from either CIDP or multifocal motor neuropathy, that MMN IROD, MMN RODS is what I sometimes use for my patient with hand weakness, which helps me not to compare between patients, but it helps me to track my own patient's journey with time. Well, in the interest of time, let's move to Jude. So Jude Kings is a specialist myasthenia gravis a nurse from Southampton, and Jude has been there since 2020. She she has experience in various clinical settings, including inpatient neurorehabilitation and community specialist nursing. And so she comes with a wealth of specialist nursing knowledge to myasthenia, and she holds a Bachelor's of Science in Adult Nursing from Oxbrook University Hospitals and specialized in neurology since 2001. Over to you, Jude, and Jude will shed more light about outcome measures and some of the swanky methods that they use in Southampton. Over to you, Jude.
Sorry, I just realised I've gone on mute. So, hi everybody. Thank you for joining us this evening. So, I'm just going to talk briefly about the app, or it's an electronic personal health record that we use at Wessex Neuro Centre. So, it basically it's either an app that people can use or from an online portal, and it helps to encourage patients to co-manage their healthcare, and that's really important with people with conditions like myasthenia, a long-term condition, to help them take a bit of ownership. One of the key things, it helps them to really connect with the team. So there's a direct messaging service which comes directly through to me. I get an email pinged through saying a patient's left a message, and that's monitored by me. One of the pitfalls is I'm only 4 days a week, but we do have admin support who cover it for the additional day. So they also, it allows patients to access their clinic letters, test results, appointment reminders. Again, really helpful for things. People can monitor their blood results so they can see, have a better understanding of how treatments are affecting them. We have lots of educational materials, shared decision-making tools. But the key thing for today is talking about the fact that people can can complete out the questionnaires, so the patient-related outcome measures. So the three key ones that we tend to use on the myasthenia site are the EQ5D, and it's not a myasthenia specific, it's a generic health-related quality of life questionnaire. As you'll see, there's 1 out of 5 domains, so it covers mobility, self-care, usual activities, which is things like work, family, leisure, pain and anxiety or depression. The key thing I tend to focus on is the bit on the right, which is the visual analog scale, where we get patients to rate it's a percentage, so it's of their best health that they can imagine versus the worst health. So we also look at MG-ADL and MG-QOL15R. So I won't talk about ADL because Pablo's kindly covered that one. So just a quick again, the MG-QOL15R, it does what it said on the tin. It measures the patient's perspective of the impact of myasthenia on their quality of life. It's a revised version. It's a 15-item scale where they score 0 to 2 with a maximum score of 30. And it does cover a broad range of domains, including physical, social and psychological well-being. So this is how it looks when the patients fill it out online. So quick and easy to do. Hopefully takes a few minutes. These were the old forms before we updated it to the QOL15R. So I'll give an example. In a case study, we had a 57-year-old female with MuSK antibody positive myasthenia. She'd been treated with rituximab in 2021 and had a very long period of remission. She contacted me through the app, so sent a message to me saying that she was getting a lot of symptoms, and at the same time she filled out her questionnaires. So she was getting persistent double vision, bulbar symptoms. She was slurring of speech, choking, fatigue on and chewing, short of breath on exertion. And I could see straight away that her ADL had increased from 6, which it had remained fairly stable post-rituximab. It had gone up to 14. And the quality of life had gone up from 5 to 12. At that point, she'd been started on statin. So we did wonder whether that, there are some case reports of whether that had, worsened her myasthenia. So stopped the statin, but we increased her prednisolone at that point. Kept in regular contact, and she kept doing her scores. And actually I kept looking and going, there, nothing's changing. Things seem to be going in the wrong direction. So she then contacted me again, sadly, no improvement at all. And at which point, we're in September, her EQ5D, which is the general health one, whereas it had been 85% prior to this relapse, it had now gone down to 25%. Her ADL score had actually gone up to 18, and her QOL15 was up to 52. So managed to arrange, and this is all without seeing her. Fortunately, she's not someone that I felt I needed to contact because we were having lots of regular emails. She's a very reliable patient. She's a ex-nurse. I know her very well. I knew that she would be telling me what I needed to hear. So actually, just through messaging and by seeing all of these, I was able to book her in for some plasma exchange. One of the challenges is she doesn't live locally, so she relies on a car journey, a ferry, and then another car journey. So I was able to bring her clinic appointment forward so that we could actually physically assess her as well, but with plasma exchange booked on after clinic. And then we arranged that for as a bridging therapy before we then gave some more rituximab. And when she was seen in clinic, her composite score was 33. So this is the graph form that it shows you. So as I said, this is where she'd had rituximab. This was in her QOL and her ADL. And again, like Pablo was saying, they correlate very well. So B is where she was, her period of remission. And then C and D is when symptoms are starting to get worse. So both her and I can see that visual scale. And so it helps her know, actually, I know that things are going wrong because it's going in the opposite direction to how it should be. So I have another case study of a young girl. I think she was 21 when we first met her. Acetylcholine positive generalized myasthenia. Her initial symptoms were she had ocular, bulbar, and upper limb weakness. She had a thymectomy for hyperplasia, and she had been doing quite well. So she was fairly stable. However, she would say to us, "Oh yeah, I'm okay," thinking that, you know, that this was the best she could get. We had quite a few medication challenges. So she was intolerant of azathioprine. She'd had some side effects, really didn't get on with it. Being a young lady, possibly, you know, potential for family planning in the future, it meant that we couldn't give any other non-steroidal immune suppression, such as mycophenolate or methotrexate. She tried a high dose of prednisolone, but she had lots of adverse drug reactions, so side effects. So she put on a lot of weight. She was getting insomnia. So we reduced that back down. So she was on just 5 milligrams once a day. But she did find that pyridostigmine, 60 milligrams 4 times a day, was really helpful. And she didn't get any side effects. So she was quite happy to stay on that. But we saw her in clinic and it was quite interesting. So her QMG was 3 because actually she, you know, and clinically, I imagine you'd both agree that you'd look at that and go, okay, that's not too bad. That's, you know, it's not so much of a severe symptoms. However, her EQ5D was 60%. ADL was 6, but it was the QOL score of 15. What a lot of these didn't show is that actually she did have significant improvement. She still had some mild bulbar symptoms, but she had upper limb weakness and particularly finger extension weakness. And I think, Channa, you mentioned that earlier on, that the composite QMG doesn't allow, you know, doesn't give us capacity to be able to assess for that. But for me, it was also the key thing of the impact that this was having on her quality of life. Her reduced grip strength, she couldn't drive a manual car anymore. So she had a loss of independence. She wasn't able to work. She was an avid horse rider. She used to go to the gym. She suddenly couldn't hold the reins. She couldn't lift the weights. Things like doing her hair and her makeup, even eating, she was, you know, tearing food rather than slicing it. And so it's having a really big impact on her mood and her sort of her social activity. She was isolating herself more. So at this point, one of the consultants I work with, Ashwin Pinto, had said, well, you know, let's see if we can put her forward for efgartigimod, because actually we're quite limited in what else we can give here. So we applied for efgartigimod, but we thought, actually, how else are we going to be able to monitor this? How can we really sort of review the results of, you know, the improvements that she may get? So we got one of the neurophysios did some additional outcome measures. So did the 9-hole peg test, grip strength, and Purdue board. And also, I didn't say in clinic, so apart from her QMG composite, her finger extension weakness was 3 out of 5 at that point. So following her 8th cycle of efgartigimod, she had significant improvements, and you can see her quality of life. So her composite score had gone to 0, which we would expect because it's not accounting for much anyway. But actually, her finger extension weakness was 4 out of 5. She was so much happier. Her EQ5D, she was suddenly rating, it was almost the best life possible at 90%. ADL score of 0, and quality of life had dropped significantly down to 1. saw the physio again and did some repeated hand function tests, and all of those were, there'd been a significant improvement in that. And as a result, she's now back horse riding, lifting weights, driving, putting on a makeup, being able to do a bra, all of the things she couldn't do before. So I'll give an example. In a case study, we had a 57-year-old female with MuSK antibody positive myasthenia. She'd been treated with rituximab in 2021 and had a very long period of remission. She contacted me through the app, so sent a message to me saying that she was getting a lot of symptoms, and at the same time she filled out her questionnaires. So she was getting persistent double vision, bulbar symptoms. She was slurring of speech, choking, fatigue on and chewing, short of breath on exertion. And I could see straight away that her ADL had increased from 6, which it had remained fairly stable post-rituximab. It had gone up to 14. And the quality of life had gone up from 5 to 12. At that point, she'd been started on statin. So we did wonder whether that, there are some case reports of whether that had, worsened her myasthenia. So stopped the statin, but we increased her prednisolone at that point. Kept in regular contact, and she kept doing her scores. And actually I kept looking and going, there, nothing's changing. Things seem to be going in the wrong direction. So she then contacted me again, sadly, no improvement at all. And at which point, we're in September, her EQ5D, which is the general health one, whereas it had been 85% prior to this relapse, it had now gone down to 25%. Her ADL score had actually gone up to 18, and her QOL 15 was up to 52. So managed to arrange, and this is all without seeing her. Fortunately, she's not someone that I felt I needed to contact, because we were having lots of regular emails. She's a very reliable patient. She's a ex-nurse. I know her very well. I knew that she would be telling me what I needed to hear. So actually, just through messaging and by seeing all of these, I was able to book her in for some plasma exchange. One of the challenges is she doesn't live locally, so she relies on a car journey, a ferry, and then another car journey. So I was able to bring her clinic appointment forward so that we could actually physically assess her as well, but with plasma exchange booked on after clinic. And then we arranged that as a bridging therapy before we then gave some more rituximab. And when she was seen in clinic, her composite score was 33. So this is the graph form that it shows you. So as I said, this is where she'd had rituximab. This was in her QOL and her ADL. And again, like Pablo was saying, they correlate very well. So B is where she was, her period of remission. And then C and D is when symptoms are starting to get worse. So both her and I can see that visual scale. And so it helps her know, actually, I know that things are going wrong, because it's going in the opposite direction to how it should be. So I have another case study of a young girl. I think she was 21 when we first met her. Acetylcholine positive generalized myasthenia. Her initial symptoms were she had ocular, bulbar, and upper limb weakness. She had a thymectomy for hyperplasia, and she had been doing quite well. So she was fairly stable. However, she would say to us, "Oh yeah, I'm okay," thinking that that this was the best she could get. We had quite a few medication challenges, so she was intolerant of azathioprine. She'd had some side effects, really didn't get on with it. Being a young lady, possibly potential for family planning in the future, it meant that we couldn't give any other non-steroidal immune suppression, such as mycophenolate or methotrexate. She tried a high dose of prednisolone, but she had lots of adverse drug reactions, so side effects. So she put on a lot of weight. She was getting insomnia, so we reduced that back down. So she was on just 5 milligrams once a day. But she did find that pyridostigmine, 60 milligrams 4 times a day, was really helpful, and she didn't get any side effects, so she was quite happy to stay on that. But we saw her in clinic, and it was quite interesting. So her QMG was 3, because actually she, and clinically, I imagine you'd both agree that you'd look at that and go, okay, that's not too bad. That's, it's not so much of a severe symptoms. However, her EQ5D was 60%. ADL was 6, but it was the QOL score of 15. What a lot of these didn't show is that actually she did have significant improvement. She still had some mild bulbar symptoms, but she had upper limb weakness and particularly finger extension weakness. And I think, Channa, you mentioned that earlier on, that the composite QMG doesn't allow, doesn't give us capacity to be able to assess for that. But for me, it was also the key thing of the impact that this was having on her quality of life. Her reduced grip strength, she couldn't drive a manual car anymore, so she had loss of independence. She wasn't able to work. She was an avid horse rider. She used to go to the gym. She suddenly couldn't hold the reins. She couldn't lift the weights. Things like doing her hair and her makeup, even eating, she was, tearing food rather than slicing it. And so it's having a really big impact on her mood and her social activity. She was isolating herself more. So at this point, one of the consultants I work with, Ashwin Pinto, had said, well, let's see if we can put her forward for efgartigimod, because actually we're quite limited in what else we can give here. So we applied for efgartigimod, but we thought, actually, how else are we going to be able to monitor this? How can we really sort of review the results of the improvements that she may get? So we got one of the neurophysios did some additional outcome measures. So did the 9-hole peg test, grip strength, and Purdue board. And also, I didn't say in clinic, so apart from her QMG composite, her finger extension weakness was 3 out of 5 at that point. So following her 8th cycle of efgartigimod, she had significant improvements, and you can see her quality of life. So her composite score had gone to 0, which we would expect because it's not accounting for much anyway. But actually, her finger extension weakness was 4 out of 5. She was so much happier. Her EQ5D, she was suddenly rating, it was almost the best life possible at 90%. ADL score of 0, and quality of life had dropped significantly down to 1. Saw the physio again and did some repeated hand function tests, and all of those were, there'd been a significant improvement in that. And as a result, she's now back horse riding, lifting weights, driving, putting on a makeup, being able to do a bra, all of the things she couldn't do before. So hopefully that shows that it's a variety of different scores, I think, sometimes that we need to use, that not everything captures, that you have to you need to keep quite an open mind, don't you? You might see someone who maybe they've got a composite QMG score of 3, but actually it's considering all the other options and all the discussions as well around that of what's important.
Thank you, Jude. That's an excellent, very practical presentation. And you're absolutely right. The myasthenia gravis composite score might not capture all the muscles that are affected in myasthenia. So being innovative is helpful if you're familiar with what you're doing, and then also do the same thing the same way. So one of the questions I have for you is that when you do the MG-ADLs in the clinic, it depends whether your clinic is in the morning or in the afternoon. So how do you account for this, Jude? Because some patients are better in the morning and they become worse as the day goes by.
Yeah, and it's something we recognise at Southampton. All of our myasthenia clinics are in the morning, and it's something recognising that we are only seeing them for a very small snapshot. It may have been, like you say, first thing in the morning, they haven't fatigued. They've maybe just taken a dose of pyridostigmine. They're usually at their best. So it's trying to take that into account. It's a very difficult one of knowing sort of the best way of managing that. I know one of the sort of questions I wanted to put to both of you as well is around pyridostigmine use, because I know that there are some studies and sort of some papers that suggest that pyridostigmine should be withheld for 12 hours pre the composite QMG score. But practically and reasonably, I don't know if either of you do that, because I think a lot of our patients, if we said, please don't take your medication beforehand, it presents a bit of a challenge then of, and how do you recognize that, or where do you document that? What do you do about that?
It's a very good question. I think I do a number of clinical trials in myasthenia gravis, and where they mandate that before you do QMG or MG-ADL assessments for the clinical trials, you need to stop the periodostig mean for 12 hours or more. But in the clinical practice, I don't advocate this unless I'm not sure whether this patient's how the myasthenia is developing, or if I want to know that if before I drop the steroids down, that whether I can come down on the periodostig mean. So at that point, I might tell the patient, why don't you delay it and see how the symptoms, whether you get any symptoms, and if they're comfortable to then delay it and come to my clinic. So that's my practice, but regularly in clinic, I don't normally advocate them to stop periodostig mean before I see them in clinic. What about you, Pablo? What is your experience in this?
I don't tend to stop it because you want to see how the patients are in their day-to-day life. Already you only get a snapshot, but it's artificial to stop it when patients usually take it. I mean, I would stop it if there's diagnostic uncertainty, and I want to know whether how someone is off periodostig mean in order to examine them in the sort of natural state. That'd be the most common reason for me to ask them to stop it. But I think that your second case was very important to see to show the limitations of the outcome measures that we use. If it's sort of good for mainstream myasthenia gravis, but if you have sort of unusual or less frequent symptoms such as focal hand weakness, it's a little bit like a multifocal motor neuropathy that you really need to examine very carefully the hands, or have outcome measures that focus on these very, very focal weaknesses.
Mm-hmm.
Yes, that's correct. I think again, customizing to your patient's needs might involve or increase better engagement. Jude, do you find some patients they are excited when there are new therapies? They do the scales regularly, but do you find that they lose interest? And how do you, if that's the case, how do you maintain engagement for the patients to continue to complete their outcome measures?
I think just trying to encourage them as much as possible that actually if we have that information, it helps us to help them a little bit better. So rather than threatening, saying, right, we need this for data, you've got to fill this out, actually saying that this is really helpful because it's really useful for you to see. And often we will, turn the computer screen to a patient and say, look, have a look at this on the graph. You can see what's going on. This is really, really good for you to use. I used to send out a reminder patient to all our patients, but we have over 550. I can't do that. So it's just trying to teach people the importance of doing them, but also just recognizing the challenges of doing patient outcome measures as well, that sometimes they can. I mean, I'm glad that the quality of life has 15 has gone for the revised version, because the old version was, people would ponder very much over the, is it somewhat or a little bit or very much, whereas now it makes it a little bit more straightforward, and they can be quite quick and easy to use, but it's trying to just encourage patients that they need to take they need to be involved in their care. It's very much about partnership working, and if they're giving us the sort of the best scores, or doing their best to give us the information we need as much as we can do it vice versa.
Nice one, thank you. I think there is a question on the Q&A. Maybe Pablo, if you could kindly answer this. The question is from Dr. Tanweer. The question is, would you retreat myasthenic patients with rituximab based on their MG-ADL or composite myasthenia gravis score, or would you rather use the CD19 cell count as a better marker, or when to retreat rituximab patients?
Good question. I mean, I think that I do monitor CD19 count and would retreat patients if these cells emerge. But if someone's symptomatic, then I would treat the patient rather than the cell count. And it might be that rituximab, it doesn't work for everyone. In fact, it's sort of unclear who benefits from it, who doesn't. It seems to work better in people who don't have myasthenia gravis for a long time. So there's definitely about 50% who don't respond. So you'll treat the patient. But in terms of monitoring for patients who do respond, you use I would use a CD19 count. What's your how do you work, Channa?
Yeah, I think my approach is the same. I would treat the patient and use the biomarkers as complementary to my decision making. If the patient is stable and the CD19 cell count is 0 and the MG-ADL is improved, then I would delay the next rituximab or not jump onto treating it. But if the for example, CD19 cell count is rising and the patient is stable, I will watch and wait, and I will treat based upon the patient's symptoms. So yes, MG-ADL and composite scores are really helpful. So I think in the interest of time, unfortunately we'll have to conclude this the first part of our webinar. I'm very grateful for Pablo and Jude for your excellent presentations and engagement in discussion with the real practical scenarios in managing myasthenic patients. So with that, I will end this session